Good morning, everyone. Could you please turn your cameras on? Excuse me. Okay, there's a few still students showing absent. Please scan your QR code if you're here. I can see these are the students showing absent in Kursky: Bella, Olga, Abhijit, Vishal, uh, Therese, then Trina, Kristen, Dahlia, and Rabia. These are the students still showing absent. Any of you here? Okay, let's give a couple of minutes for them to join. Do you have any question before we start the lecture? Excuse me. Do you guys have any question? Question? Come here, so quiet. Come on, guys, wake up. It's
I do have
11.
a question.
Okay.
Are you able to go over any of the questions on the exam with us?
Actually, that is, not the policy. We cannot go over the questions, but I can go over anything in particular. If you have something in mind, I will be more than happy to go over that. But it's not that I can go over questions.
Okay. Yeah, because there was a question about when a nurse should step in when giving medication. That on there that I wanted to go over, but if you can't go over that specific question, I understand.
Yeah, I cannot go over like any of the questions completely, but as like if you remember the question and if you have confusion about any of the options, answer options, yeah, I can discuss that.
I don't remember the answer options. I think I blacked out there for a minute.
Okay, what it was about? Can you repeat that again?
It was a question about if a new nurse is administering medication, when the nurse watching should step in, saying that they don't understand that medication.
Okay. So I'm just guessing
It was
without
a
knowing the
select
names.
all.
Sorry, what was that?
It was a select all that apply.
Okay. Was there any medication name listed, or it was more like generic?
No, there was a medication name listed. I just don't remember it off the top of my head.
Okay, yeah, then it's a little tough because if I know the name of the medication, I can give you a hint like what is important for that. Because if they're asking that when the nurse, was it about that when the other nurse will intervene, or is it like it was about assessing if the patient understand any teaching points or side effects or anything like that?
It was if the new nurse understood the medication, when the nurse should intervene.
Okay,
But I
so
can't give
okay,
you details right now, so I don't
no
think this
worries,
is
no
going
worries.
anywhere.
Yeah, it looks like then they probably the new nurse they are saying doing something which he shouldn't be doing based on the risk factors associated with that. Okay, these are the
Professor,
students. Yes.
this is Abhi. Could you please mark me here? I'm actually driving right now. I'm gonna be home in like the next 5 minutes. So I don't have
Absolutely.
access to a computer to scan.
Yeah, I'll do it right now.
Thank you.
You're very welcome. You're in now. Anyone else experiencing that issue? Because there are a few students still showing absent. Bella, Olga, Kristen, these are 3 students still showing absent.
Hi, Professor. Kristen's almost home. She's just needs a few extra minutes. So if you could mark her present also.
I'll mark her as soon as she comes in. Just let me know whenever she comes, okay?
Oh, I had a question about one of the test questions.
Uh-huh.
Um, there was one that had like typos on it. Um, like some words were missing letters, or like the the words were jumbled up, and I wanted to know if like that question would still count, or anything like that.
Uh,
Because it was a select that I'd apply, and then some of the options were like misspelled or something, and
do you
the
do you
words.
have
Yeah.
any? Do you remember any of them? Like what it was about, which question, anything like that, so that I can double check them.
I can't remember what it was about.
Anybody
I
else
just I
notice
just
that?
remember.
Because
Yeah, I
There were
also noticed
two
There
that
was
of
the
them.
one
there were a
about
few that had,
SSRIs and
yeah.
risperidone.
okay, I'll look
Yeah.
into that.
Okay, thank you.
Mhm. Okay, so Olga, Kristen, 2 students, 1 and 2. These are the 1 students. So let's move on. First of all, one thing I noticed positive is that majority of you did way better on calculations on this exam. Okay, last exam, it was a different picture, completely different picture. So that definitely a huge difference. So well done, um, for doing better on that aspect. But now the other angle, we all know that we are not where we wanted to be. So there is room. There's a room. There are cracks. There are gaps to fill. Okay, for sure. Um, one of the basic things I saw is, and it's again, it's common in generic cohorts when you don't have complete clarity about some concepts. And I did notice that some of the questions they were basic, but because he didn't have any big background, so those were not answered correctly. So I would strongly recommend that please take a look a night before on your PowerPoints, go through everything highlighted. Okay, see what you know and what you don't know, so that you can ask question, pay attention, stay focused when it's the material we are going over in the lecture, what you don't know about, so that you go with clarity. As I said, it's okay to come with not knowing it, but not okay to leave in the same manner. So that is something we need to fill. Other is, I felt like some of the questions, when you need to connect the dots, uh, how to relate the answer options with the concept of it. For example, like if somebody's asking you to identify the adverse effects of a medication, you need to know on which receptor or what part of the body it works at. Where does it work? Because majority of the time, the adverse effect is associated with that particular part, such as there was a question, I don't know specifically it was about antihistamine or it was name of the medication, but you need to figure out like what does these antihistamine do? And I was giving an example like Benadryl, the phenhydramine, in last week's lecture. Like you know what they do? They sedate people, they make you slow, sleepy, drowsy, dry. And then other things to connect is like, is there anything else showing there which patient taking can potentially increase the risk? That's also a risk. So know how to connect these things. That's something also which I noticed on a couple of the questions. Um, okay. Okay, Olga, you're here. Just notice your
Yes.
text. Okay. Okay, all right. How about Kristen? Kristen, are you here as well? No, say. All right. All right, guys. So, okay. 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 Do you see my full screen? This gentleman with blood pressure cough? The full screen, right? Not in the presentation mode, right?
Yeah.
Okay. Now, please make sure once again, as I said, please follow what I tell you to. Who's that? Okay, Olga, I checked you in.
Okay, thank you.
You're welcome. So the steps I tell you before the lecture, like going over your PowerPoints, then during the lecture what to do, after the lecture what to do, what resources to use, please use them. Because look, as I said, I'm here to help you. I'm here to hold your hand, but I can only hold your hand if you let me hold it. Okay, I can only help you if you let me help you, and in that process of improvement, both sides has to play a role. I cannot do it alone, and you cannot do it alone. So it's a collaborative approach. We have to work as a team very closely. Stay in touch with me. Something bothers you, let me know. You're not understanding something, let me know. Not only that we are coming to know that we don't know after the exam or during the exam. Okay? I know you are busy. You have other things to do, but hey, this is important. This is important. So I need your 100% dedication, focus, so that we can be productive during the lecture as well as productive in your exams. Because when we leave something out, we start slipping from that ladder. And that's common. You're not the first one. And I want you to understand, don't take it too hard on yourself. Okay? I have seen, Kristen, you here as well? Okay. Okay, I checked you in. Please try to be on time, guys, because it takes time away from our learning, right? But anyways, now one thing is before the lecture, read them. During the lecture, don't try to write down everything. You know, you are in a professional course, and you have to change or adjust your approach a little bit. I'm not saying that completely change it. What's working for you, please keep doing that. But if not, then at least include certain things, suggestions, what I give you. Don't try to just that, okay, whatever he's telling, I'm going to write. Whatever he's telling, I'm going to write. Then you are not understanding what I'm telling you. So if you don't understand, you're not going to retain it. Or you will end up spending more time to understand on your own. Third, if you're not doing anything, means you're just looking at the screen, but if you're not taking some notes, means notes, what I always say is don't try to write everything, just a little footprint leave there. When I was talking to some students last week as well, as in leave footprints, that where, on which slide do you need to come back and revise where you saw that that is important. I've been told that's important. I need to come back here. Leave that note on your downloaded version of your PowerPoints, or whether it's a Word document, or just write on a piece of paper, your notebook, what you need to come back and look at. Then third, get involved in the lecture. Get involved in the lecture. It's real important. Your mind is real smart. Okay, it's going to tell you everything to keep you at ease, at comfort, and that is not what we want. It's going to tell you that, hey, I know you worked yesterday hard, that this Professor Sra doesn't understand that. Hey, you just sit and look at it. I'm going to grab every inch of the slide, whatever he's telling. As soon as you ask me, I'll make it available for you. But I can tell you that as soon as you ask during the exam, it's not going to show up. So don't let your brain trick you. Give it a task to do while you're listening to the lecture. Tell it, hey, this is the most important thing. Stay focused. When I tell you take a note, take a note. When I tell you highlight it, highlight it. Don't take a break. And your brain will get conditioned to. Is there a reason, guys? Majority of the cameras I see off. Is there a reason? Is somebody, are you guys experiencing any issue or what? Abhijit told me that he's on way. Stephanie, Mecca, Sabrina, Ferry, Nabila, Harjo, Jenny, Munir, Cherry. Is it just me can't see them, or you guys can't see either? Can somebody
I
confirm?
can see everyone.
I can see
Camera's
everyone
on.
as well.
Okay,
Their
can every
cameras are on for me.
okay, can everybody see Harjot?
Yeah, I can
You
see
said
her.
hard drive?
It just say HD on my screen. It doesn't. I don't see her on the camera.
I can see
Now I
her.
see her.
Yeah, I can see her.
Oh, you can.
Yes,
Okay.
yeah.
there, yeah.
So it's probably something on my end. Okay. So like I see like half of the cameras, it just showing their names. This is something, I think have seen different issues with this Teams. We used to have Zoom, but that license was canceled and started using it. So it's still, I think, in that phase of development, making improvements. It's not 100% there yet. But anyways, so after the lecture, guys, set up a timeline for you that, hey, within 24 to 48 hours, I'm going to spend hour and a half to 2 on each chapter I studied this week. Okay. So that is important, because the more you're going to delay, you're going to spend more time and less retention. Outcome is not going to be there, what we're looking for. Then as you are spending that time to learn the material, develop your study guide the way I have been telling you, not in a different way. Because the problem is, if you adopt a different way, you may miss which was important, but at the same time, you spent your time which you could have spent on what's important, and you missed. So please follow the way I'm telling you to. And then as soon as you're done, give it a reading and right away start practicing questions every single day. 20 to 25 on ATI, on your Evolve, your book questions, each one of them. Now, it sounds like a lot. It is a lot. It's not that it's not, but it is needed. It's required. We cannot skip these crucial steps. And then as you improved on calculations, keep practicing because we do not want to step back. We want to keep moving forward. Okay. So once again, when we in the lecture going over something highlighted, important, I'm telling you important, make sure you know it, you understand it, and you revise it well. Everybody clear? Any question before we start?
What do you recommend for today's class? Because sometimes after that exam, we come in and it's exhausting to sit here for another 4 hours and try to comprehend what we're listening to when you
I'm sorry. What do I recommend for what? Can you say that again? I'm sorry, we were breaking.
coming into today's class after doing the exam, because after doing the exam and coming into the class, sometimes it's exhausting and it's hard to process the information that we're getting.
Yeah, thank you for sharing. And I was the first one not to agree with it. Okay, I didn't want it. Okay, this is the first time I'm doing it. I never done it. I would say this is not ideal, but it was from the upper management at the campus level that they had some clashes. I don't know if it was about the courses or it was the rooms or what it was, but something they said that they have to do this. They didn't have any option. That was the only reason it was done, and I am 100% with you on that. I, I agree that it's not that productive. Yes, your mind is tired. So previously, what we used to have is here lectures on Monday, Tuesday, and then Wednesday students go to the campus and then take the exam before they engage in an activity like in a skill lab or something at campus. That's how usually it goes. But as I said, because of certain reasons, they just couldn't do it this time.
So what would you recommend for this though?
I mean, if you guys wanted to kind of, talk to Professor Supneed about that, I mean, you can. If there is any options, I can convey that message as well. Um, but as far as like as I said, like I tried to explore different options, but I couldn't find a solution because it's not just one step. And if it was me on campus, I would arrange it in a different way. But I can't be there physically, so I have to rely on other proctors. And then based on what their schedules are, what their classes are, what their availability, what hours, and then what are the days when the rooms are available. So those were multiple factors which did not give me any option. We can talk to your student advisor, you can talk to Professor Supneet and see if there's anything, if there's any change in any scenario, and if there could be any better option.
I'm just curious,
No,
do you think our test scores are like showing, that we're tired, after like the schedule? Do you think
No,
there's a
honestly, it's hard to say, but I don't feel like, for me, it seems like because and that's match aligns with all other genetic cohorts. It's a similar way that there's slight gap in understanding certain concepts and then connect them to the actual question and the answer options. That's what the basic issue I see. And that's the most common thing in all genetic cohorts, all of them.
Do you think we can get like, I guess, practice questions more often to kind of figure out how to apply the question, or I guess the
Yeah.
work to the questions.
Yeah, that's why I'm saying it from the very first day. All resources what I given you, it's not to give you hard time, it's to help you, because I know that as a generic cohort, you need certain things more than an advanced placement cohort, and you need more clarity in basic concepts as well as try to apply it. The more you're gonna attempt the questions, you do it right, perfect. Even if you do wrong, now you know it, and the next time you know it correctly, that you're going to answer it correctly. So you need to attempt more and more questions. And I'm planning something else. Give me about a couple of days or so, 2 3 days. Hopefully I'm going to come up with something else to support you guys additionally from what you have now. Okay. I can't let you go through this alone. Okay. I'm thinking as soon as I was looking at scores this morning, I started thinking, what else to do? What else to do? Okay, so I will keep doing whatever I can within my abilities. But as I said, I cannot do it alone. I need your full attention, full dedication on the resources the way I'm telling you. So please do that for me.
I think we're using the resources, but it is definitely that day one after the exam trying to comprehend what you're saying. And then day two's better, but then you have to kind of go and reteach yourself, which takes away from that studying time on day one because you might not have processed it as much because your adrenaline levels and everything are going
Yeah.
all over the place from the
Agree.
exam.
Yeah, it's challenging. It's not easy. But let me see. As I said, give me 2 3 days. Let me. I'm thinking about a couple of things, and hopefully, if we are able to do that. But for that as well, I will need your help to join me, so that we can go over certain things. We can do certain activities where you can see what I'm telling you, and then you can understand things well, and you're able to connect them with the question, and that will give you better clarity that okay, this is what I was getting wrong and this is the right way to look at it, and here is the right answer option. But it's again, it's a team effort. Okay, all right, so let's move on. Okay, and
Professor.
as yes, go ahead.
I'm in the waiting room for the online because I'm home now.
You're in the waiting room.
Yeah, I pressed the link that was on Outlook.
Okay, but you're here now.
Hey, but I'm through my phone.
Okay, but so you're saying that does it tell you like on from your computer is you're in the waiting room, or you just not understanding?
Yeah, it says hey, I'll be hang tight. Someone should admit you shortly. Or can someone just
Uh,
email me the link because I can't find it. I tried emailing it through
you can
WhatsApp because the
you
internet
okay,
couldn't.
open Canvas on your computer. Uh,
Okay.
I'm sorry, Teams. Okay, open Teams. Then go to your calendar, go on today's date. That's where you will see the link and join.
Okay, sounds good.
Okay, perfect. All right, guys, let's move on. We got 3 chapters to cover. Once again, guys, focus when I tell you it's important. Make sure you know that, okay? So today we're going to go over this hypertension, okay? Hypertension, antihypertensive drug. We'll know what the hypertension is, what the drugs are, how do they work, and what are the important aspects about those drugs, okay? And important information you need to know when developing a nursing care plan or associated with your nursing process. And a lot of times students have question, basic, very common question. Oh, it's a lot of material. What should I focus on? Well, I'm telling you what to focus on. You don't need to know everything about every drug, okay? Know as a class what their mechanism of action is, general things like common adverse effects, But when I tell you this is important, that is something you cannot skip, but because they are going to test you on that, here or there, now or later, you'll be tested on that. So make sure you know that. And when you develop your study guide, that's how you develop. Don't try to write down everything for every drug listed there. Okay? Don't make it a standardized way. Make it unique. That is the whole reason. Otherwise, I would just make a study guide for you once and just give it to you, hand it over to you. Could do that. That's not productive. So bring what is important only. Don't like, okay, for every drug, I'm going to write down mechanism of action is important, side effect is important, this is important, that is important. No, for every drug, everything is not that important. They cannot ask you thousands of questions. There's an only a set number of questions they can ask you. Like here, only 60, final 80, and collects from somewhere from 75 to 140, whatever. That's it. So you know it. They cannot ask you everything about every drug. They're going to ask you important things about that. And that's what you should focus on. Please understand the concept. You cannot know everything. And as I said, very simple. You don't even know to know. You don't even know. You need to know everything. And why should we waste our energy on that? Focus what is important. Okay. Now, first of all, when we talk about hypertension or antihypertensive, now what are antihypertensive? Break it. Anti and hypertension. So hypertension is high blood pressure. The drugs which acts against the high blood pressure, those are antihypertensive. And what they do, they just bring it down, bring it to normal. Those are antihypertensive. Um, are they just all one type? No, they're different types. Is it just hypertension is just one umbrella term, is just one type of hypertension? No, they're different types. Is it they're less, more associated or concerned with different population? Yes, as on this slide. With older population, 60 or above, the normal they count is as 150 over 90. So anything above that, that is your hypertension. But anybody younger than 60, they're more strict. They wanted to keep things under control, right? So that is little stringent. That is 140 over 90. Anything beyond that, that is hypertension. Everybody clear? That is the criteria. Now, the second thing about the types of or the stages of hypertension. Now, normal, somebody normal, well, perfect. We're not worried about it, okay? Then there's pre-hypertension, then stage 1 and 2 hypertension. And as we move up, that's what tells you the severity, the more severe the condition is. And I'm going to show you here an example. For example, somebody has 120 over 80, perfect, normal, right? So elevated is then when there is a 9-point jump in, even if it's only on systolic part, okay, that is elevated. That's when you educate them about changing lifestyle modifications, exercise, reduced salt intake, all that kind of stuff, right? Quit smoking. And that will continue with any stage of hypertension they go through. But you start with that. Then stage 1 is when there's another jump of 9 points from 130 to 139, and or either or. It could be both, it could be one, systolic or systolic and diastolic, both, 80 to 89. That is stage 1. And now the severity increases with another jump, anything beyond 140, and then anything beyond 90, that is stage 2 hypertension. But if at any point the systolic crosses 180 and diastolic crosses 120, that is a red flag. That is an emergency. Patient should be in the emergency room. Understood? Okay, so this is the same information. Okay, now. Okay, Ramanpreet, I got your message. Now, classifying them. Now, you will come across patients where your patient knows, or you are able to determine the reason behind hypertension, what is causing, and then more than half you will have no idea. I would say like even 80-90%, you won't know why. And that is called idiopathic or essential or primary hypertension when you don't know what the reason is. Why? And the rest 10%, secondary hypertension when there is a known reason behind it. Okay, for example, preeclampsia during pregnancy when patient develop that. Okay, when somebody has renal artery disease, somebody is having sleep apnea, somebody has thyroid condition, or maybe they're taking a medication which is increasing the blood pressure. So that is secondary, which is a smaller part. Majority of the part that falls under essential or idiopathic or called primary hypertension when we don't know what the reason is. Clear?
Excuse me, Professor, can you go back over the examples of known? Because you said preeclampsia, and what were the other examples?
Or for the secondary? Yeah,
Yes.
for known, like renal artery disease, so kidney disease, sleep apnea, thyroid conditions. So those are some
Okay.
examples. Okay. Okay. Now, we know the problem. Blood pressure is high. Now, solution is what can we give them to bring that to normal level? That's what we're looking for. Well, next question is which medications? And then out of those, are there some which are first line? So that's what the next question is. Now, the different class, like your adrenergic drugs, uh, your vasodilators, and the ones which are highlighted, they are important, right? ACE and ARB. You guys heard about that? What ACE and ARBs are? ACE are angiotensin converting enzyme inhibitors. ARBs are angiotensin receptor blockers, okay? And I'm gonna go over what that means. ACE or ARB. Remember this thing. ACE or ARB, always. They cannot be given together. Severe hypotension can happen, severe adverse effect. You never give drugs from these two classes together. They never get mixed. It's an important point. And collects the test you on this all the time. ACE and ARB, never give them together. It's always ACE or ARB, one or another, and these are the drug of choice. When you are putting a patient the first time, these are the drug of choice. Then there are calcium channel blockers, CCBs, diuretics like chlorothiazide, vasodilators, direct renin inhibitors. And we're going to go over drugs one by one. Now, these are your adrenergic drugs. The first one we're talking about, adrenergic. Now, adrenergic, they could act centrally, they could act peripherally, okay? Now, centrally acting, such as your clonidine and methyl dopa. These both drugs are important. Clonidine, you will see patients, they're having really high blood pressure risk, and you wanted to bring it down. You will see this clonidine, or other medications given. It's not well controlled. You may see a low dose of clonidine given along with that. Methyl dopa. Why it's important? I'm going to repeat it further as well. This is the drug of choice in pregnant patients with hypertension. That's important. Okay. Now, next class, alpha blockers. Okay. Alpha blockers. They're alpha 1 blockers. Alpha blockers. And You will need to know. They might ask as a class, they may throw in the name of the drug. You should be able to identify which class it belongs to. So remember, I'm going to go over again that these class of drugs ends with zosin, Z-O-S-I-N, zosin. These are alpha blockers. Okay, these are alpha blockers. Then they're beta blockers, like your propranolol, metoprolol. They always end with LOL at the end. LOL, those are beta blockers. Okay, then they're dual acting, labetalol, carvedilol. Okay, um, so adrenergic drugs, what they're used for, number one, like what we're just talking about, hypertension, to manage blood pressure. What are other indications, diseases, conditions where these medications are used? Glaucoma. What is the problem in glaucoma? Increased intraocular pressure. It's like hypertension of the eye, correct? Tension in the eye. So these drugs help to reduce that as well. BPH. And the drugs used are your alpha blockers, which ends in zosip. And we'll go over that. But it just simple, basic things I'm sharing with you. Now, adverse effect. Different class of drugs will have different adverse effect. But in general, let me take you back and then we'll step forward again. What is the problem in hypertension? What is the problem with your patient?
Too much
Blood pressure.
Yeah, high blood.
Blood pressure is high, right? That's the problem, correct? Everybody agree on that?
Yeah.
And why we are giving the medication now, antihypertensive, what it's going to do?
Lower it.
Lower. Everybody agrees with that? Now let me tell you the simplest way to remember what could be the most common adverse effect. If you ever see antihypertensive or for any drug, the most common adverse effect would be completely opposite. Now, blood pressure was high from normal. Your medication is going to bring it down, but there is a risk that it may bring a little too much down than expected. Now, what is that called?
Syncope.
Hypotension.
Hypotension. Remember, high is hypertension, low is hypotension. So this patient, high risk of hypotension, which can cause syncope. Okay, high risk, they can fall. And there are drugs which can cause first dose syncope, means that when they're taking the very first time, make sure you tell them, take it at night, bedtime, and do not walk for a few hours after that, because your blood pressure might fall dramatically because you still don't know how it's going to act on your body. So you're taking first time. And some drugs has a high risk than others, such as alpha blockers. So please know this, okay? Know this. Alpha blockers. How to identify? The drugs ends in zosin, Z-O-S-I-N. Okay, and some of them little difference, sin as well, like tamsulosin. Okay, and doxazosin, terazosin. These drugs can cause orthostatic hypotension, so patient can fall. So you have to consider safety risk, fall risk. Number two, first dose syncope. The very first time they're taking this drug, it should be bedtime, and they should not walk after that. They can fall. Everybody clear about that point? Yes? No?
Yes.
Yes.
Okay, this is important. Okay, never miss alpha blockers. What the big concern is, and the problem is going to come where, that how do I know which drug is alpha blocker if they just gave you the name of the medication rather than the class name? I mean, you knew orthostatic hypertension because of alpha blockers, but hey, I don't know what are those. Well, they end in Zosyn or UC-syn, like as you said, tamsulosin, right? Flomax, which is given in BPH patients, and your terazosin, doxazosin, that is extremely important. Now, there are other
I
things.
have a question.
Yes.
So it's the first dose you should really watch for, but is it until their body just gets used to it, or is it like second dose, it gets better? How would
Yeah,
you
it
explain
just
it?
because these drugs have a high chance of dropping the blood pressure as compared to any other antihypertensive drug. So we know that, hey, this has a high risk. So we have to be careful at least the very first time because it's unknown. What if the patient is weak? What if patient is already confused? What if patient is taking any medication which can cause additive effects? So all those factors can contribute and increase the risk. So we are trying to minimize that risk. Does that make sense? Okay. All right, now if you see again, to clarify, guys, you see there are other things listed as well. But what did I highlight? Two things. Is that right? Everybody agree with that? Yes? And that's what important. That's what they will test you on. They're not worried about constipation. They're not worried about depression here because that does not happen common at probably long-term thing. But hey, the patient even can fall the very first after very first dose. That's what they're worried about. Try to understand what is important now. Okay, now these drugs can interact. Now, what is the biggest risk with these medications? Blood pressure going down, too much down, right? Now, anything which can bring the blood pressure down, that develop the risk of falls, right? Or hypertension, such as alcohol, benzodiazepines, opioids. They all do that, correct? They make your patient slow, sleepy, drowsy, dry, and dropping blood pressure, correct? So that is important. Look into your patient's profile, ask them what else you're taking. That is high risk. And that's what exactly we'll be focusing on. Is everybody with me on that? Yes? Okay. Now, let's talk about these two drugs. Remember I told you these drugs, centrally acting adrenergic drug, clonidine and methyl dopa. These are important drugs, okay? These are important. Now, how do they work? Well, the class itself tells you centrally acting. Clonidine starts from C, means acting centrally. What do? They stimulate the alpha 2 adrenergic receptors in the brain, which causes what? A decrease in production of norepinephrine, epinorepy. Okay, because these gentlemen, epi, they increase the blood pressure. So they are stopping the responsible party who is causing blood pressure to go high. That makes sense?
Yep.
Okay. So now, methyl dopa, as you see the bottom line, highlighted, that is extremely important. What is important? What if a patient comes, like, normally, any normal adult who just diagnosed with hypertension? Oh, it's so easy. Okay, ACE or ARB. Hey, it's either going to be ACE or ARB. What if the patient is pregnant? Well, the game changed. You got to make sure the patient is safe and the baby's safe. Correct? So now what do? Well, we got to make sure we give them what is safe to give, and that is your methyl dopa. So somebody asks you, what is the drug of choice in pregnant patients who has high blood pressure? Your answer should be methyl dopa. Understood? Clear?
Yes.
That's all you need to know about these two drugs. Okay, next. Here comes important class of drug again, alpha blockers. Specifically, they block alpha 1 receptor, okay, which is responsible for that. Once again, block alpha 1 adrenergic receptor. Now, what does it do to decrease the blood pressure? Well, this guy, remember now, let me ask you again. What did I tell you? What is the biggest reason, whatever the biggest risk with alpha blockers, which ends in zosins?
Hypotension?
Hypotension. Now, when does hypotension happen? When arteries dilate or when arteries constrict?
Constrict.
When they dilate.
Oh,
Dilate. When you are constricting, you're pacing it out. It goes fast. Okay? When you're dilating, the supply increase, but the pressure drops. Okay? The vascular resistance decrease, causing a decrease in blood pressure. So dilation puts your patient at high risk of hypotension, but it's needed to decrease the blood pressure. So once again, we know these drugs, what we're talking about here, they are going to dilate the arteries. So next thing should be, hey, I gotta watch my patients for hypotension. Very important about this class of drug. Okay. Let me repeat that again, because we know they dilate arteries, causing your patient risk of hypotension. So when should you give them the very first dose?
They're laying down.
And when do they lay down? When do they lay down?
they're
Right,
going to
though,
sleep.
at night, yeah.
At bedtime, right? So know that the first time. And why we are doing that? Which to prevent which condition?
So they don't fall.
Hypotension. Orthostatic hypotension.
Or orthostatic hypotension or that first dose syncope with this drug. Correct? Next question. Who are your patients for this medication? These zosins. Zosin, yeah, we know that they decrease the blood pressure, but this drug primary indication is in patients with BPH, benign prostatic hyperplasia. Who are those? Your older men, over 60, 65. Those are the ones who develop BPH. Everybody knows what BPH is? I think I did explain that one day, right? Did I?
No. Can you go over it though? I don't remember.
Yeah. So I give an example of a garden hose. When it's all new, clean, there's no obstruction, water is you turn the tap on, water flowing freely at the other end, correct? Now, over time, build up, maybe either there's kind of dirt particle, something or that, or you just put a clamp on it, a tight clamp. Now, what is the tight clamp is going to do to the flow?
Slow it
That's an
down.
obstruction. Slow down, right? It's going to slow down. And that's what happens in your BPH patient. The prostate gland, it acts like a clamp on your urine passage and it obstructs the urine. And now they're it's dribbling. They can't pass the urine completely. And now if it's not going out, where it's staying? In the bladder, right? So they have bladder, the urinary retention. It's uncomfortable, pain. And the more the urine is going to stay in there, they're high risk of UTIs, which can eventually travel to kidneys, causing pyelonephritis. So that is the problem. And this medication dilates. Remember, dilates. So it dilates the vessels. Now they can urinate better, at least if not normally. And only one time for one indication, this medication can be used in female patients. That's if they developed kidney stones. Remember, they dilate. Where does the stone pass through? Urinary passage, correct? And they dilate the vessels. The vessels dilate, they flush it out. Agree? Make sense? That's the only indication in female. And that's all you need to know about this class of drug. Either they ask you about as a class or if they give you this medication, but you need to know both ways. As a class, what it is, and what are the drugs under the class, because you need to identify. So write down alpha blockers, right? And then for you, leave a footprint. What is it? These drugs ends in zosin. And as soon as you see drugs ends in zosin, it should click in your mind, oh, these are the drugs, these are alpha blockers. Hey, I was told. Now the next footprint is high risk of hypotension, first dose syncope, who it's used in, BPH. That's all you need to know. Only 4 or 5 lines. That's all you need to know about this. Forget about everything else. All right? Okay, let's move on. Everybody's awake? You guys are so quiet. Come on, guys. Don't be so quiet. Okay. Say something better than what I'm telling you, right? It's like all boring, right? Okay.
We're just tired from the
I know,
test.
guys. Okay.
Yeah,
I
that's why we're
completely
quiet. Uh-huh.
I wish I had a solution for that. I wish I could do something. I'm so sorry. I wanted to, but I just don't have it. Okay. But I do feel it. Okay.
Professor,
Now next one. Yes, sir.
you said BPH is most common in males above 60, right?
Correct. Older
What
men.
is that? Older men.
Yes.
All right.
Yeah. Okay. Now, next important class, beta blockers. Okay, beta blockers. Once again, what do we give it for? Well, we've been talking from last 40 minutes. Hypertension, correct? Hypertension. That's what it's used for. Well, how does it work? Well, it says in the name, beta blockers. It blocks beta. What is beta? Receptor. Which one? Beta 1. Why beta 1? Because remember, beta 1, one heart. Beta 2, two lungs. So beta 1 associated with heart. Beta 2 associated with lungs. So it blocks beta 1 means, hey, it acts on heart. And that's what your hypertension, the condition is associated. So they always acts on beta 1, never on beta 2, okay? But if they are non-selective, I'm going to tell you that angle as well. That's important to know. That could be a problem in some patients, not in all. So they reduce the secretion of renin, and renin is responsible to increase the peripheral vascular resistance, which causes an increase in blood pressure. Okay, so it reduces blood pressure. Now, how do you recognize or identify who are the beta blockers? Once again, write down beta blockers. Hey, these drugs ends with LOL. Once you see, you know that, you know what beta blockers are. LOL, metoprolol, atenolol, esmolol, all these are beta blockers. Everybody clear? Okay, now let me tell you another important thing. Please know that well. I told you, right, that the drugs, they will act on beta 1 receptor, which is on heart, but they are the one which are called specific. The others are non-specific or non-selective. See here how they're classified: selective and non-selective. Selectives, which only acts on one, the beta 1. So we are not worried about that they will do something else on the body, but non-selective, such as your propranolol, timolol, well, they say, oh, we are really good in handling multiple things, right? So yeah, I'll fix high blood pressure, but hey, let me look around. What else I can fix in the body? You say, no, thank you. Okay, we don't want that. In some patient, the reason, if your patient has asthma COPD, okay, asthma COPD, which part of the body it's associated with? Lungs, correct? Lungs. So beta 1 associated with heart, beta 2 associated with lungs. You see the link? So if they're non-selective, means they're not only going to act on beta 1, they may go travel to beta 2, which is on lungs. Correct? So hypertension patient, we're trying to fix that. But now they went wandering around, roaming, right, and reached lungs. But on lungs, they will produce an opposite response. They will constrict the airway, constrict the airway. Now, what is the problem with asthma COPD? Respiratory issue with breathing. And if you constrict it more, what they're gonna do? They're gonna YELL at you. Yell at you, right? Like, what are you giving me, nurse, right? So we don't want to do that. Correct? So please understand the importance to put a filter that any patient who has asthma COPD, do not give them these beta blockers. If you have to, make sure they are selective, not non-selective. Everybody's clear about that point, understood? Any question on that?
I don't understand the right part of this chart. Honestly, the with a blocking activity.
Okay, so beta blockers, it acts like any drug, okay? Any drug, to produce its therapeutic effect, it has to go and shake hand with receptor in the body. Without attaching it to the receptor, they're not going to do anything. Now, beta blockers, they shake hand with who? The beta receptors, correct? Now, in the body, there are two types of beta receptors, beta 1 and beta 2, correct? Beta 1 are associated with the heart. This is what we need to attach it with to decrease the blood pressure. But there are blood pressure medications, these beta blockers, which are not selective, which can act on the beta 2 as well, which is on lungs. Okay, on lungs, it causes an unwanted effect, the bad effect, adverse effect. It constricts the airways. And when airways are constricted, then breathing becomes difficult. So your patient who has asthma COPD, which is already struggling with the breathing issues, now they are struggling even more. That's why we're trying to prevent that from happening. And so these are divided, selective and non-selective, just to kind of give you an idea, hey, that if somebody has this condition, use those selective ones. And if you have to do them, hey, make sure you are able to filter those patients who can be at very high risk if you give this medication. And these are the non-selective ones. Don't give them this. Okay? Make sense?
Yes, thank you.
Now, my next question. How do you know? These are only like 3 drugs. And how do you know in general? Is there a way, an easy way to know which ones are selective and which are non-selective? Isn't it hard to kind of figure out? Right? How would you know which is selective, non-selective? No, they're not going to tell us. Now, what if I give you a very easy, busy tool which you will never forget, and how easy it could be for you to know? You guys want that? Yes? You're silent on that, guy. You should be like,
Yes.
yeah,
Yes, please.
Yes.
Okay. Wake up, wake up, wake up. When something good comes, I'm saying, like, grab it, okay? Okay. Here you go, guys. Remember I told you beta 1 on heart, beta 2 on lungs, okay? Now, the beta blockers starting from A through N, okay? If the drug's name, beta blocker, ending in LOL, starting from A through N, that is your selective, means you don't have to worry about as much COPD part in this, okay? But if their name starts from O through Z, that is not selective. That's a non-selective. Ring the bell. Raise the red flag. Means look for, if your patient has asthma COPD, do not ever give it to them. Is that easy now? Just remember one of them, A through N. That's okay to give, right? A through N. If it doesn't fall in there, well, that's a problem. That's it.
Just to clarify really quick, non-selective is what we won't give a patient that has trouble like breathing or asthma stuff, right? And then
Yeah,
selective,
asthma COPD, we should not be giving non-selective, which O through Z will. Right? So everybody clear now? Anybody who still did not understand or don't know how to identify which one is what? Everybody's okay? So when I tell you guys develop your tool, you're developing study guide. You develop study guide when you are writing about beta blockers. Write this down right next to it. That A through N, O through Z, these are selective, non-selective. Make that is what called study guide. Important things, and now creating tools to memorize them in an easy manner. Okay, now let me give you another tip. When we talk about vasoconstriction, vasodilation, right? So always A, C goes together, B, D go together. Now, in heat, what we turn on? Air conditioner, AC, correct? So remember, AC goes together, and then B, D goes together. Now, what the reason is? A means alpha receptors. That will cause constriction of the vessels, eventually increasing the blood pressure. Okay? B means beta. That will cause D, means dilation. That will decrease the blood pressure by causing vasodilation. Clear? A, C, B, D. So if the drugs are acting on alpha receptors, you will see some exceptions, okay? Some exceptions. Only few. But majority, remember this, acting on alpha, they're going to cause constriction. Acting on beta, they're going to cause dilation. So you should be able to now identify which can cause blood pressure to increase or which one to decrease. Okay, now these are some examples like your labetalol and carvedilol. They are beta blockers, but they're dual action. They don't fall in those selective areas. They are their own class. Dual action. So they act on with the heart rate decrease by blocking the beta 1 receptor, and cause vasodilation by acting on the alpha receptor blockade system. Then um, um, these drugs usually, such as this labetalol IV, you will see in patients in emergency department who are going through hypertensive crisis, means extremely high blood pressure. Maybe they're experiencing a heart attack. Okay, they use this drug to bring the blood pressure down slowly in stepwise approach, like with 20 by 20 by 20. It's not that you just try to drop it down. It never happens. That is the wrong approach. You're putting a patient at high risk if you do that. So stepwise approach, slowly, and labetalol is very common in doing that. Okay. Now, next class, guys. As I said, ACE or ARB. Now, these drugs are your drug of choices to start with. Somebody diagnosed with hypertension, ACE or ARB. Now, how do you know which drug falls under this ACE inhibitor class? First of all, know what it is. ACE inhibitor, they inhibit ACE. Well, what is ACE? ACE is an enzyme. What? Angiotensin converting enzyme. But why we are blocking this enzyme? What this poor guy does? It's not that poor. Okay, this guy is not that poor. Causes a lot of problem. This is the guy who's responsible to increase the blood pressure. Why? Because it supports conversion of angiotensin 1 into angiotensin 2, the chemical from 1 to 2. And the angiotensin 2 is the one which causes hypertension. And by blocking this enzyme, now we are blocking that support who is going to help angiotensin 1 to get converted into angiotensin 2, which was going to raise the blood pressure. Understand? Yes, no? Okay.
So, oh, Professor. So you're saying that angiotensin 2 is the one um that brings it down, or I think I got it mixed up. What you said.
Okay. I'll show you at a different spot what I'm talking about. Okay. I'll show you. Okay. You know what? Let me. Okay, I will explain it if I don't see that on the slide here. Okay, in a
Okay,
different
cool.
one.
Okay,
Yeah,
sounds good.
but angiotensin 2 is the bad guy.
Okay,
Okay,
that's fine.
and
Yeah.
ACE helps ACE1, which was not that bad, but angiotensin gets converted from 1. So angiotensin gets converted into 2 with the help of ACE. So ACE is the bad guy who helps our enemy to show up, right? Creation of that enemy, angiotensin 2. So we are blocking the helper for the creation of the bad guy, angiotensin 2. Okay, but I'll show you in a different way. Now, these drugs are first line for heart failure, hypertension patient. Now, the next question comes is, how do I know which drugs are ACE inhibitors? So please, once again, when you write down ACE inhibitors, first thing you write, they end in PRIL, P-R-I-L. Okay, so as I said in the first lecture, organization skills important. This is what organization is, because if you don't put them in this way, how to identify, how they you gonna get things mixed up, which is ARB, which is ACE, which is beta blocker. That's why I'm indicating here. See, these are highlighted. PRIL is highlighted here, and that will help you to identify that ACE, they end in PRIL. You don't need to remember the name of all those drugs. You all need to remember PRILs are ACE inhibitors. As soon as you see a drug with PRIL, you will know that's an ACE inhibitor. Okay, I hope you're understanding my point, the importance of organizing these little things. Now, how does it work? As I said, inhibit ACE. Okay, so you start with an angiotensin 1. So you write down angiotensin 1 at left. Now point an arrow forward, okay? And on top of that arrow, from top to bottom, put another arrow downwards, write down ACE, ACE, ACE. That is the enzyme, okay, which helps the conversion of the angiotensin 1, which was on the left side, into angiotensin 2. Without its help, it cannot convert. So when it helps, angiotensin 1 gets converted into angiotensin 2, which causes what? Constriction, vasoconstriction. And remember, constriction causes blood pressure to go up. Is that right? That's what we talked about, right? And when you block ACE, now angiotensin 1 cannot convert into 2. And if there's no angiotensin 2, it cannot cause vasoconstriction. If there's no vasoconstriction, the blood pressure cannot go high. Is that clear? Yes,
Can I
understood?
get that slower and a little bit more like I did not catch any of that.
Absolutely. Why not? Okay. Remember I said we are starting with angiotensin 1. Okay. We are worried about angiotensin 2, which gets converted from angiotensin 1. So angiotensin 1 gets converted into angiotensin 2, which is a troublemaker. We are worried about it. But the conversion depends on the help from who? ACE, the enzyme, angiotensin converting enzyme. That's what the name says, right? Angiotensin converting enzyme. But it's converting from 1 to 2. And we know 2 is the troublemaker. Why? Because it causes constriction, vasoconstriction. Your vessels carrying the blood, they constrict. And as soon as they constrict, the pace of the blood increases, blood pressure go high, right? So once we block the ACE, we block the conversion of angiotensin 1 to 2, which eventually blocking vasoconstriction. And once you block the vasoconstriction, it's not going fast. Blood pressure goes low. Is it clear? If somebody still did not get it, please ask again.
Thank you.
You're welcome. Okay. Now, primary effects of that, right? Primary effects, as we say, like on cardiovascular system, guys, on heart, right? And then also protects the kidneys as well. Okay, because kidneys, with all your renin and all that, aldosterone, there is called, like, you can simple words you can say that hypertension in the kidneys as well. The kidneys goes under stress and eventually it's hurting your kidneys as well. Okay, it's damaging the kidneys, so they also kind of protect the kidneys as well. Now, once again, important, if your patient is diagnosed with hypertension, high blood pressure, what is the first line of treatment for, or if somebody has heart failure, right? Now, you're supposed to give them antihypertensive. What would you give?
ACE inhibitor.
Okay, anything else you can give?
An ARB.
Okay, remember, ACE or ARB. It could be ACE, it
okay.
could be ARS, never together. Another drug in your heart failure patient, which you might see along with that, could be beta blocker, okay? The third one, beta blockers. So if you see options in questions, patient hypertension, what is the first line in patient has hypertension, or you see patient has heart failure, okay? So these are ACE, ARB, and beta blockers. So these drugs will be the right choice, okay?
Hi, Professor. Can you repeat that? You said ACE. Which one?
ACE or ARB, okay? Or it could be a beta blocker.
What about
Okay.
ARAs?
Which one?
ARAs.
Say that
ARA.
again.
ARA.
I'm gonna go over everything, okay? One by one.
Okay.
I'm connecting these dots based on how you could be tested, ask question, because that's how they get things mixed up. Okay. So let me just respond to this real quick. Okay, now, as I said earlier as well, that they have protective effect on the kidneys as well. So on heart as well as kidneys. So please know that, because it reduces the pressure in the kidneys, which is your glomerular filtration pressure gets down. High glomerular filtration pressure damages the kidney. So they have protective effect. Now, how does it correlate with certain type of patient population? If your patient is diabetic, okay, if your patient is diabetic and they may have hypertension now, or they're at risk of developing it, just suppose they have it. Now, diabetes, not well controlled, having hypertension, what do you think is going to happen to the kidneys? They're slowly and steadily keep damaging the kidneys. They may end up going on dialysis. Okay. Why we're talking about that here? If your patient is diabetic, they are at risk of kidney damage over the period of time. It's a silent killer. And we just said ACE inhibitors has renal protective properties. So if your patient is diabetic, hypertension, ACE inhibitors are the drug of choice for them. Make sense? Yes. So please know that. Very important.
Can you repeat that one more time?
Yeah, I was going to
So
say
your
the same
diabetic
thing.
patients over period of time at a risk of damaging their kidneys. Okay. And ACE inhibitors has renal protective properties, means they have qualities to keep the kidney safe by keeping the glomerular filtration pressure low, because high can, damage the kidneys, and they keep the patient safe, or the kidneys safe over time. So they are the drug of choice for diabetic patients with hypertension, not for diabetes. Diabetic patients with hypertension. All right, let's move on. Now, what are the things we should be worried about when we are giving this medication? So now there are many here. But what is important? Please do not miss this. ACE inhibitors, very unique adverse effect, dry, non-productive cough. Dry, non-productive cough. There's no sputum, okay? There's no mucus, but they're coughing like anything, even that they are having trouble sleeping, and all that can happen. And if that happens, they should call the doctor. Most likely they'll be stopped from that and switch to a different drug. Okay, very important thing.
Could you repeat that?
Okay, most important adverse effect associated with this class of medication, which is ACE inhibitors, is dry cough. Dry cough. So if your patient calls you, hey, I'm coughing like crazy from last few days. So what medication are you taking? And if you see an ACE inhibitors, what might be the reason behind it? Okay. Now it can cause like angioedema and all that, where it shows, here, like, angioedema it can increase the potassium levels as well. And certainly, like, any antihypertensive you're giving, it can cause hypotension based on that particular patient, underlying conditions they have, any other drug they are taking. So once again, we know about that part. ACE inhibitors, important thing, dry, non-productive cough. Few other things to consider. Potential interaction. Remember on the previous screen, I said it can increase the potassium level as well, okay? Potassium level, which is hyperkalemia, right? Hypotassium. So if your patient is taking a potassium-sparing diuretic, such as spironolactone, so spironolactone let the body hold potassium in the body, okay? Like, okay, you're my friend, so you can keep potassium here. Now, this drug, ACE inhibitor, also increase the level of potassium in the body, which can eventually cause what? An additive effect, too much of potassium in the body, and your body doesn't like that. Okay? So you need to monitor this thing and filter this out. The patient is not on potassium-sparing diuretic. Lithium levels can become toxic real quick if they are on taking this medication. And same NSAIDs also affect the level. It kind of reduce the effect of ACE inhibitors. Okay. Now, here's an example of ACE inhibitor, captopril. I mean, there are many, but I just put up like few in here. What's important about this? Why you selected this one? We know that it's going to decrease the blood pressure and kind of reduce the risk of heart failure, myocardial infarction, like a heart attack in future. Important point about this is the certain patients, for example, you have a patient who has hypertension, but his liver is not fully working. It's not fully functional. Okay? You have a liver disease, which is cirrhosis, right? So liver issue. Now, what is liver's role in medication efficacy? Liver is the organ responsible for what? Metabolize the drug, right? Liver is involved in metabolizing the drug. Kidneys are responsible for excreting the drug, right? Now, liver, if it's not healthy, it cannot metabolize the drug. It cannot break it down into simple form, into more effective and more soluble form to flush it out from the body. Now, two things can happen. One, the drug is not metabolized means it did not convert it into more effective form. And if it's not turned into effective form, well, it's not going to produce therapeutic effect. The patient will still have high blood pressure. Correct? So majority of the drug will just go unutilized out from the body. Okay. And also the drug may keep circulating in the system because it did not broken down, can cause toxicity as well. Now, why captopril is highlighted here? Not only captopril, lisinopril as well. So captopril and lisinopril. These are not pro-drugs. What that means? Pro-drugs are the drugs which are completely ineffective. They are not in their therapeutic form until you take them and liver transform it into a different form, okay? Converts into an active form. They're completely inactive. They have no ability to produce its therapeutic effect just by breaking down. It needs to be converted. It needs to be converted. Those are called pro-drugs, okay? Now, what if the patient's liver is not healthy, not fully functional? Well, if you give them those drugs, which are pro-drug, it can't be converted. So in those patients, you can give them captopril or you can give them lisinopril, which does not require that biotransformation conversion from one form to another. It just needs to be broken down and will produce therapeutic effect in those patients. So even their liver is not capable, well, you don't even need the liver to play that function of converting into that form to be effective. So these are the drug of choice in patients who do not have a healthy liver. Got it?
I have a quick question.
Uh-huh.
How do they become effective? What causes them to become effective if they're not effective in their
Okay.
primary?
Drugs are in different forms. They are in active forms, they are inactive forms. You need to convert into another form in order to be active. And the liver is the one which converts into the form which is capable of producing the therapeutic effect. Certain drugs, they cannot act it in that form itself. The body cannot sense it. Okay, it cannot combine with receptors. It just goes unnoticed and flushes out. It has to be converted. You cannot use certain things in the raw form. Okay, it's like you have to cook it, right? You have to convert it into a different form. So similarly, certain drugs, it has to be converted, because if you take it as such, they are ineffective. They're ineffective. Body, as I said, body doesn't sense it. And then you need conversion. And the only part who can do it is the liver. And if it's not healthy, that's not going to happen. So when it converts into the form which your body, your receptors can accept, can feel, sense, bind to, that's when the therapeutic effect happens. As I said, if they don't bind to the receptor, nothing happens. In the form they are taken, it never produces that effect. They can't bind. Okay. All right. 63. Oh my goodness, we are behind today. Okay. All right, let me pace up a little bit. So this drug, enalapril, okay? Nothing much to worry about this. It just, I put it so that you kind of know about more drugs. Sometimes they ask about this, sometimes about that, but it's just a class effect. Same thing, it's an ACE inhibitor, works in the same way. Nothing much to worry about, okay? Now, next important one is ARBs, your angiotensin receptor blockers. Now, on the previous one in ACE, what did I tell you? That they block the enzyme ACE, which blocks the conversion of angiotensin 1 into angiotensin 2, correct? That's what I told you. But these drugs do not block that step. Angiotensin 1 gets converted into angiotensin 2. But after that, this is where they come. They do not let make the friendly bond with the receptors. Okay, they block the receptors. And without binding to receptor, nothing happens. Okay, and I may have a slide, I'll show you that. Now, angiotensin 2 receptor blockers, how do you identify them? Who are they? Remember the previous one? ACE inhibitors ends with, what do they end with? ACE inhibitors. Pril. Now, write down ARBs or angiotensin receptor blockers, they ends with sartan, S-A-R-T-A-N, sartan. Once you see sartan, that's an ARB. And now let me give you another important point, write that down as well. Sartans or ARBs do not give in pregnant patients. They're not safe in pregnancy. Do not give them. Okay. Okay, here you go, guys. That's what I was saying now. Here, look at this picture to visualize it better, okay? Think about ACE first, ACE inhibitors, okay? The previous pills. Angiotensin becomes or converts into angiotensin 1 when kidneys release renin, and ACE released from lungs and causes angiotensin conversion into angiotensin 2. And right here, that's where the ACE inhibitors work. Remember, ACE is coming up here. And once you block this, you stop it, no ACE, right? Angiotensin 1 cannot get converted into 2, which was going to increase the blood pressure. Clear? On the other hand, in ARB, it's letting conversion of angiotensin 1 to 2. It doesn't do anything here, but what it does is it blocks the receptors where these are going to bind angiotensin 2. And after that bond is formed, that's when vasoconstriction was going to happen, increasing the blood pressure. So they're blocking those receptors and bringing the blood pressure down. Is everybody clear? Yes? No?
So it blocks the receptors on A2.
Okay. The blockers, they're called angiotensin receptors. Angiotensin receptors. And this drug blocks. That's why, and it's number 2, the angiotensin 2 receptor. That's what it blocks. That's why it's called angiotensin 2 receptor blockers.
Got it.
And that's where angiotensin 2 was going to bind. Remember, angiotensin 2, the troublemaker, that was going to bind there. Okay. Is the picture clear to everybody, guys? What's happening in hypertension and where are we blocking it with which class of the drug? Yeah, as far as what we have covered so far.
So essentially, if I'm understanding correctly, the ACE is gonna lower BP after angiotensin 1, and then the ARBs are gonna do it after angiotensin 2.
Yeah, so at that step. So technically, in any patient with hypertension, what's happening is that from angiotensinogen, renin gets involved, angiotensin 1 formed. ACE involved, angiotensin 2 formed. Angiotensin GO binds to the angiotensin 2 receptor, causing vasoconstriction, causing blood pressure to go high. That's what's happening in hypertension patient. Now, when we give them ACE inhibitor, it's blocking ACE, the enzyme which is helping the conversion of angiotensin 1 to 2. So when you block it, you don't have much of the angiotensin 2, which was going to make a bond with angiotensin 2 receptor, causing vasoconstriction and causing high blood pressure. On the other hand, the ARBs, they are simply blocking the receptors. Okay, so let me give you an easy example. Without sitting with the receptors, okay, it cannot happen. The blood pressure cannot increase because that's where the chemicals are released, which are causing vasoconstriction and increasing blood pressure. Now, what I do is your ARB, they compete. Okay, they compete with the angiotensin 2. It's like that there's one table, 4 chairs available on a restaurant. You're going for lunch. Okay, You're going for lunch. Now you have somebody else you see like, oh, it looks like they are looking at the table. Okay. Now, in order to occupy the chair and the table, what you do? You go there where the table is, where the chairs are, you sit on it. Now, can the other person sit on it? It's fully occupied. They can't, right? They can't sit. Similarly, this ARB go and block the receptors. Now angiotensin cannot go and sit there anymore. It cannot push the ARB away. It's once the receptor blocked, as long as it's effective, this gentleman too cannot go. And if cannot connect to bind with the receptor, can cause vasoconstriction, can cause increased blood pressure. And that's what's happening. Understood? Okay, I'm taking it as yes. All right, guys. You guys are so quiet. Come on. Okay. Now, ARBs. I don't want you to worry about anything. They are not known to cause cough or that kind of stuff. Okay. Now, as I said, to identify them, they end with sartan. Okay, sartan. Now, I told you guys, very important, sartan or ARBs as a class, do not give it to patients who are pregnant as well as who are breastfeeding. And it is a black box warning on the bottles. You will see that black box warning, the black label on it, warning you don't give it in pregnant patients or lactating. Never ever. Can cause fetal toxicity. That's very important about this class of drug. And also be cautious if somebody's liver is dysfunctional, not fully functional, or they have an active renal disease. Okay, it can still be given, but you have to be more cautious. But most important, this pregnancy black box warning. That is extremely important. Okay, I'm not worried about other things much. Okay. Any questions so far, guys? Anything else which you may wanted to ask? And we'll take a break in just a few minutes. Okay, sorry, it just got extended a little bit more. Because this is a more complex. These this week chapters are a little more complex. So I'm just trying to go slow. Okay. Any question, guys? No? Okay to move forward? Yes? Okay. Now here comes another class, calcium channel blocker, CCB, calcium channel blocker. Well, question number one, how do we know which class is calcium channel blockers? Write that down. They end in pine, P-I-N-E, amlodipine, nicardipine, nimodipine, all these are calcium channel blocker, except two common drugs. They're also calcium channel blockers, but they don't end with pine. That is diltiazem and verapamil. Diltiazem and verapamil, those are the only one which do not end with pine. Everything all is. Okay. They cause relaxation of the smooth muscles. Okay. Relaxation of the smooth muscles results in what? A decreased resistance, the decreased SVR, vascular resistance, and which eventually decreases the blood pressure. The more the resistance is, more the blood pressure is, higher the blood pressure is. Okay. Here it looks like Pine. And I said there are only two commonly used, verapamil, diltiazem, which falls under non-dihydropyridine. That is based on their structure, dihydropyridine and non-dihydropyridine. That's how they're classified in. But in general, just know everything except these two, pine, they are your calcium channel blockers. So they are used for, as we've been talking about, hypertension. They're also used for angina pain. Also used for migraine. Even beta blockers can be given for that, migraine. Raynaud disease. Raynaud disease is when, for example, an extreme cold temperature, the tips of extremities, okay, tips here, or on the feet, they get cyanotic, bluish. Why? Vasoconstriction. Vasoconstriction decrease the supply of oxygenated blood, and those ends becomes bluish. That is called Raynaud's syndrome. And these drugs causes what? Vasodilation. Vasodilation means more oxygenated blood supply, and then they become normal again. Okay. Now, diuretics. Okay, diuretics. They are also very common drugs. Very common drugs, usually kind of little light, and they are used very commonly in the beginning. Okay, so they are, as I said, very common. They are also called like water pills, very commonly, general word, water pills. Why? Because they increase the urine output. More urine, the patient is going to pee more. That's why they're never a good idea to give at night, because then they can't sleep. They can go pee at night. Okay? What they do here, now your body, not body, I'm sorry. The problem here, hypertension, is related to heart. Heart is working hard. It's working hard. The blood pressure is going high. It has to pump the volume. Now let's relate it. Pump is working hard to pump the volume, correct? Now what we do, this drug, when give, what is doing? It's increasing the urine output, correct? It's increasing the urine output. Urine is what? It's a volume, liquid, right? Fluid. When more liquid going out, less inside, correct? Less volume. Now, less volume means now your heart doesn't have to work that hard. Less work. You reduce the workload on the heart. So you are keeping it at ease. Did you get my point? Heart has one job to do. It gets tired of pumping. You're giving, hey, I have more. Oh, you keep pumping. He's like, I'm tired, guys. Stop it. Right? So what you do is you just say, okay, you know what? Hey, I'm gonna take a few files away from you. Some patient, like somebody has, as a nurse, you had 10 patients. You're like, what's going on? I'm tired. I'm not a robot, right? Get tired. Now what you do? The charge nurse say, hey, you know what? Let me give 2 of your patients to another nurse. What happens? Your workload goes down, right? Your stress goes down. Similarly, heart is stressed out. Keep pumping the blood. And now you increase the output. More fluid went out, less workload on your heart. It's happy. Now, how do we understand and analyze that this drug is working or not, or what's happening, and what are the important factors to consider? Now, remember here, with this drug, we're talking about volume, correct? Liquid. Now, if the patient's heart is not pumping well, okay, not pumping well, so the body is retaining more fluid, right? The fluid is being retained in the body. Now the body has more fluid. How it's going to impact the body weight? Is the weight going to increase or is it going to decrease?
Decrease.
I'm sorry, you said decrease?
Yeah.
No, okay. Without taking the drug or after taking the drug?
After taking the drug, because you're losing water weight.
Correct. So I was first asking that when patients' heart is not fully effective in pumping that, so body is retaining the fluid, and what's happening to the body weight? So body weight will increase, correct? After giving the drug, now it's flushing through the urine, right? So less. So body weight will go down. So important factor to monitor is daily weight, correct? That will give you an idea that if the drug is effective or not, how it's impacting the patient. So body weight is very effective a way of monitoring the patients, especially heart failure patients who are on this medication. Okay. Also, another factor is intake and output. How much you put in the body, how much went out. That is another factor. So these are extremely important to monitor. Daily weight and intake and output. Also, monitor their electrolyte level. Why? Because, well, we are playing here with the volume. And volume, the liquid does not go alone. It does not stay alone. It does not go out alone. It takes electrolytes, sodium, potassium, along with it if it's going out. So if they are holding more fluid in the body, it's more diluted. So electrolytes will go down. Okay. When more fluid is going out, and along with that, electrolytes going out, then electrolyte balance in a form of low level. I'm sorry, the low level. Okay. So it depends that they're retaining, they're throwing more, and that volume makes a difference, the level of electrolytes. So these are important things for you to monitor. The different ones, very common here, like furosemide, Lasix, very common, okay? Then hydrochlorothiazide, very, very common. Then this spironolactone, very, very common. And whenever you see spironolactone, make sure you know this drug is called the potassium sparing diuretics. Means your patient will be at risk of keeping more potassium in the body. So your patient might be at risk of too much potassium called hyperkalemia. Okay? And your patient's heart is not going to like it. When there is imbalance in these potassium level, heart doesn't like it. If there is imbalance sodium, their brain doesn't like it. So make sure you monitor the relevant factors.
Is there any prefix or suffix for these?
I'm sorry, what is it?
Is there any like prefix or a suffix on diuretics so we can use to remember them?
Not really, because there are multiple subcategories. For example, like thiazide type. So thiazide type you see here, the hydrochlorothiazide, benzophenone, they end with zide, but there's some indapamide that ends with mide. Then metolazone zone. There's no, I would say like just one way of remembering them. But you will see very commonly, like, this, that's why I'm telling you that furosemide very common, hydrochlorothiazide very common, spironolactone very common. And this Mannitol, it's used, in patients, for example, they have head trauma, to decrease the intracranial pressure, this drug can be used, mannitol. So unfortunately, there's not one tool to remember that. Okay, vasodilators, as the name say, vasodilators, they dilate the vessels. Okay, when they dilate, the pressure reduce. Oxygenated, a rich supply of blood continued. Okay, these are your diazoxide, hydralazine. Now, minoxidil as a brand name, Rogaine, this is also used for hair regrowth. Okay, hair regrowth. I would say to a certain extent, okay, maybe not for somebody like me. It causes, once again, vasodilation, increase the blood supply. So it's giving me more, give them more food, okay? Well, unfortunately, it doesn't work on me. Okay, loss is way too great than what we can recover from here. It's like you can only pray now, right? That's what I'm at. Only pray. Okay. All right, guys. Okay. How do they work? Once again, the same way, guys. Decreasing the resistance, which helps in dilation, reduce pressure. Pressure is reduced, your blood pressure goes down. Now, who do we give it to? Well, who has high pressure? Oh my goodness, they're still asking us who to give. Okay, this drug, sodium nitroprusside, and IV form of diazoxide. This is reserved for emergency only. Somebody in emergency department with hypertensive crisis, that's when it's reserved for. You don't see in common practice. Okay, this is how your hydralazine looks like, and on the bottom right, there's a minoxidil. It comes in that the foam as well. Like Costco sells it as well, and you just kind of put the foam in there. This is your sodium nitroprusside. Okay, now let's, we are close, guys. In just a few minutes, we'll take a break, okay? I promise. Now, nursing implication. What is important, either as the whole group, antihypertensive, or the specific areas belongs to certain classes or certain drugs, okay? Number one, before you start therapy, you need to know your patient. You need to know about your patient. Assess, assess, assess. Now, remember, what we are giving for high blood pressure, right? High blood pressure. So is it important for you to know their blood pressure before giving the medication? Yes, right? If the blood pressure is dropped, why would you give it? Rather than doing good, you're hurting them, right? So check the blood pressure before giving the medication. Antihypertensive, the softwares, before you give the drug, it asks you to put the values there. Put your initial, then give the dose. Okay? Now, what we are doing here, patient has high blood pressure, we are giving the medication to manage it, maintain it. Okay? Maintain it. What would happen if all of a sudden the patient decide I'm not going to take it? What's going to happen? Blood pressure will go high again, correct? Blood pressure was high. You brought it down with the medication. Now medication is not there. Blood pressure jumped up. That's what's going to happen, right? So tell your patient, do not abruptly stop it. Do not skip a dose. Do not abruptly stop it. Agree with me? Also tell them, before you start anything new or you decide to stop something, talk to your DOCTOR, right? Doctor. Talk, talk, and talk. It's important. Also, these patients, tell them, hey, it's good to work out, stay healthy, eat healthy, work out, go to gym, do this, but, but, what is important? Supervised exercise program. Well, what that means? Do they need to have somebody watching them while they do it? If they're going to jog, if somebody needs to walk with them? No. Well, supervised means only doing those things with after creating a plan based on what they can handle, how it's going to impact them. Example, when you work out, right? Your heart has to work harder, right? Has to pump more. But what's going to happen? Stress to the heart, blood pressure high, right? So if they work too hard, problem, right? Another thing, when you work out, you sweat, correct? You sweat. You're losing volume. Along with that, you're losing electrolytes. That's a problem. Okay, so there are multiple reasons, and especially like in hot weather, they say like, oh yeah, at 2 p.m. I'm gonna go and run. Not a smart idea. So that's what's called supervised exercise program. The first discuss and craft a plan which is safe for you. Okay, educate guys, educate. Diet habits, what they put in. People don't know. They don't read the labels. Okay, they don't cook. Everybody's in rush. I'm too busy. I just don't have time. Well, you better. Okay, because drugs alone, no matter what, they can't do much good. So lifestyle changes. If they smoke, encourage them to quit smoking. Refer them to those plants. Okay, and educate them to monitor BP frequently. Okay. Once again, never abruptly stop because, gentlemen and ladies, you are at risk of rebound hypertension, blood pressure. What we're trying to fix, it's going to be even worse than that. Right? Watch what they eat. Do they have any stress at home, work, anything else? That can impact big time. Maintain a healthy weight. Huge factor. Okay, sodium, people unknowingly eating grams, tons of sodium and sugar without knowing. What is the use of, why do you need sugar and salt in milk? Tell me, why? Have you read the label? If you smell, if you're drinking, you have what you need in there. And for other things, you have resources. But it's all about more dollar amount, how to make more. Bigger corporations, they're not worried about you or your patient's health. Okay, so you will see tons of sodium, sugar mixed in milk. So it can last more. And you like the taste? It's for the taste, not for health. Okay, understand these things. Patients don't understand those deeper impacts. They just thought like, oh, milk has calcium, okay? makes my bone strong. Ooh, 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 ooh. That's half information. Complete it so they understand what they're buying. Okay, these corporations, they're making things based on what they fed in your head, what you need. In actual, you may or may not need that. Smart nurses don't trust one resource ever. Okay, multiple reputable resources, then make your opinion because it could be influenced. These companies pay TV ads, writers to write, books on them, this and that, studies, anything could be influenced. Know it yourself. Dig it deeper. Okay. Okay. Also, guys, tell them to change position slowly. Why? Their blood pressure was high. You're giving them medication to drop the blood pressure. It can drop significantly. They can fall. Safety risk. So please educate about that. Now, tell them, educate them about certain signs and symptoms could be severe. Okay. High risk. Call the doctor. Why? Remember, shortness of breath, difficulty breathing. What has to do with? Lungs. Why they can't breathe? They had heart disease. Excuse me. Heart disease is what? Heart is not healthy and heart pumps, means it cannot pump well. So if heart is kind of failing, it's gonna stop pumping or not able to pump well. Now it is probably gonna back up. And if it's backing up in the lungs, that's when shortness of breath, difficulty breathing can happen. Could be a sign and symptom of heart failure. Similarly, swelling in the feet, ankle, face, what that means? The pump is not doing well, fluid is not going out, body is retaining the fluid. That's why that swelling is. Alfred, your question?
Yeah. So, these nursing implications, just to make sure, this is for all antihypertensive, right? Not just vasodilators.
Yeah, all
Okay.
antihypertensive, and then some points might relate to only few. Okay, some might, but majority we're talking about general.
Yeah. Okay.
Okay. Yeah.
Thank you.
Okay. Also educate them not to take too hot showers. Okay, too hot. If it's too hot, have you ever felt like you took too hot shower and you're kind of feeling a little dizzy, lightheadedness? Because the vessels dilate, blood pressure drops. That's what happens. Monitor adverse effect either as a whole, or based on anything specific, like for example, orthostatic hypotension with all and dry cough with just the ACE inhibitors, right? So you have to know like about what is it generalized or is it more indicatable to any particular specific drug. Okay, perfect. Sorry, guys, it was a long chapter, but it was very complex, so I didn't want to go too fast. So that's why I kind of made you stick a little longer. So I apologize for that, but let's take a quick break. It is 1:09. We'll be back at 1:20. Okay,
Can I ask a question during break?
you can ask too.
Okay. This is going back to slide 32.
Okay,
When talking
what it was about?
lithium. So I didn't understand with the ACE and how it affects lithium.
Okay. Oh, it was about like how it can interact, right? It was lithium and then NSAID and something else, right? Three things on it.
Yeah.
Okay.
It was the lithium
Yeah.
portion I didn't understand.
Yeah. Lithium is listed there because lithium is a drug which falls under one of those drugs which has a narrow therapeutic index. Remember, a very narrow margin of safety. Okay, and when they are taken together, lithium can become toxic. The lithium level can increase.
Okay.
And when taken with NSAIDs, that is its level can decrease. That's why they're listed there.
Okay. Thank you.
Okay, you're welcome. Alfred, do you have any questions? Okay, Scott. All right. I'll see you guys shortly. Hey, welcome back, everyone. Let's turn the cameras on and rock and roll. Excuse me. Right, come on, come on, come on. Excuse me. And I know that these breaks are like really short, and you probably don't even get enough time to kind of eat or drink something. So if you have a drink with you, are drinking coffee, tea, whatever you are, it's okay if you were not able to finish it. I mean, we can have it there. Okay, I don't mind that as long as you're focusing. But I know that it may not be enough time for you to finish. Okay. Let's move on. Okay, so next chapter is anti-anginal. Okay, anti-anginal. Now, what that means is we are going to use the drugs who acts against the angina. So we need to know what angina is and how these drugs will help your patients to manage or treat that condition or any associated things. Now, first of all, angina or angina pectoris. Okay, excuse me. Your heart pump needs, what does it need?
Blood.
Oxygen?
Oxygenated blood, right? Oxygenated blood. Now, when that supply of that oxygenated blood decrease to the muscles, the heart muscles, now the heart is crying, it's aching. That's what angina pectoris is. Angina pain is. Now, what is the solution? Provide them what they're short in, right? What they're short in, oxygenated blood. You increase the supply, it will stop aching. Right? So, in simple words, you need to have a balance, right? Whatever the demand is and whatever the supply is. Why the market price goes high in something, right? When the supply decrease or the demand increase, right? That's one the whole fuss about. So here your heart needs certain amount or or whatever the normal requirement. Okay, this is my requirement guy to do this, right? Now if you give it more work, like instead of walking, now you're running. Well, it needs more now. You got to fill that, right? Then either decreasing the demand or increasing the supply, that is the solution. So once again, angina pectoris. Reason behind, once again, imbalance between the blood supply, which has oxygenated, oxygen-rich supply of blood, and whatever the demand is. When there's imbalance, that's when this pain comes. Okay, there are a few terms I want you to understand. Number one, ischemia. Ischemia means a poor blood supply to some organ, to any organ. When it's poor supply, it's called ischemia. When that poor supply of blood is related to heart muscle, it's called ischemic heart disease. Okay, shortage of blood or oxygenated blood, you can say. That is ischemic heart disease. Atherosclerosis, that's a little different because It can happen because of that, because with long time build up, the supply decreases and then can't meet the demands. Now, with myocardial infarction, it simply means a heart attack, okay? Then necrosis or death, because your muscles are, they're not getting enough supply, and there was some sort of blockage. Next slide is extremely important, so please know what I'm going to tell you to. Especially two terms, the top one, they're most important. Stable and unstable angina. What is stable? What is unstable? Now, when we just think in general, stable means like, oh, maybe that's less risk, that's okay. Unstable, or maybe some risk. That's what it looks like, right? And that's right. Stable angina gets triggered because of a reason, and it gets resolved with either stopping the reason, the activity which was causing it, or with, like you give them nitroglycerin and something comes to normal, right? Somebody was okay, but they were working out, mental stress, they felt that angina, okay? Whatever they were doing, they said, oh my goodness, it looks like I'm working too hard. So the person sat down, lay down, or they took like nitroglycerin, and that pain is gone. That is stable angina. There is a known reason attached to that, and it responds to the normal solution, which is either stopping the activity which is causing it, or the usual treatment that is stable angina. Is everybody clear about that? Stable angina, any question? Excuse me. All good? Okay, now moving to number 2, unstable. So whatever we're talking unstable, it's opposite. It's unpredictable. You don't know why it's happening. You don't know why it's happening. But now, what was the other thing you were doing? You were saying, okay, maybe it was because of that. I was working too hard. Let me sit down, lay down. Well, even if you lay down, rest, still not resolved. Other thing you were doing unstable, or you would do as a usual treatment, you give them like nitroglycerin or something. You did, still not resolved. That is called unstable angina. Clear? Any confusion? Anything you're not clear about? All good? Okay. So these two are extremely important, guys, okay? Stable, unstable. You need to know what's the difference. One, because of trigger from certain activities, and resolves by stopping the activity or with usual treatment. Unstable, unpredictable, and even with usual treatment, by resting or giving medication, not resolved. That is your unstable. Okay? Example, your acute coronary syndrome, that's something underlying cause. Now, vasospastic. Vasospastic angina, it results from spasm in the layer of smooth muscle, which kind of goes around, surrounds the atherosclerotic coronary arteries, the coronary arteries. And it usually happens when patient is resting and there's no cause behind it. But this vasospastic angina, it happens with a certain type of regular pattern, like maybe like pretty much same time of the day. Whenever it happens, same time of the day. That's when it happens. Okay. This, the old name, it used to be called like a Prince metal or variant angina. On the other hand, there's another one, microvascular. Micro means small vessels, small vessels. So it's associated with small vessels. Okay, the smallest vessels of the coronary arteries. They surround your heart and they bring the constant supply of blood, which is rich in oxygen, to the heart. That is your microvascular angina. But as I said earlier, the topmost two, the one on the top, they are the most important. Okay. Now the drugs. Okay, we know the problem. What are the drugs? Somebody's mic is on. Please put yourself on mute. Oops. Who is that? Okay. Common ones, nitrates and nitrites. Everybody heard about nitroglycerin? Everybody knows, right? Nitroglycerin, that's nitrates or nitrites. So that falls into that category. Very commonly used. Then there are beta blockers. Okay. Then there are calcium channel blockers. Now there are certain drugs which can use in acute condition and some which are for maintenance to prevent it from happening in the future. Okay, you cannot give them beta blockers and say like when they're having an acute pain. You have to give them nitrates, that nitroglycerin. And you don't give them nitroglycerin every day to prevent that from happening. Correct? So you need to know. And what are you trying to do here is you're trying to fix the problem, which was imbalance in blood supply and demand. You are increasing the supply and decreasing the demand. Some might do one thing, some might do both, either or. And we're going to go over a few things. Now, first of all, nitrates, nitrites comes in various forms. Sublingual, very common. Okay, like your nitroglycerin. Goes under the tongue because it gets directly absorbed, goes where? Bloodstream, right? It doesn't have to go through the first pass effect, liver. It doesn't need conversion. And during that phase, a lot of drug gets wasted. So here, it directly goes absorbed completely in the bloodstream, quick action. That's why we use an acute condition when it's happening now. Okay. Or IV, right? It also comes in transdermal patches, then ointments and translingual sprays as well. Okay, this is how it looks like. This is your nitrostat or nitroglycerin sublingual, which comes in 0.4 milligram, or you can say 400 micrograms, right? That's what it is. And this is for your acute. These are acute, and these are not acute. You cannot do to resolve acute pain. Okay, now these are different type of medication and different way to use it. First of all, how do they work? Okay, how do they work? So let me show the next slide first. The patient is having hard time. They did not have enough supply. Well, these drugs, they cause dilation. Vasodilation increases the blood supply. Okay, the coronary arteries dilate, more oxygenated blood reaches, and you tell them, hey, help is here. And that aching stops, right? That's what the problem was. Now, going back to this slide, as everybody know, let's pick up an example, this nitrostat, the nitroglycerin sublingual tablet. Does everybody know what's the protocol to use it?
Isn't it take and wait 15 minutes, and if it doesn't go away, you call 911. You could give another, I think, for nitro.
Okay. Excuse me. Let me go over that.
Might
Everybody,
have it
please
mixed up.
focus. No worries, no worries. Let's clarify. Make sure everybody knows it, guys. I'm taking an example of this nitrostat or nitroglycerin sublingual tablets. So when a patient experiencing angina pain, acute pain, what you're going to do? They're going to open it up, okay? And that's the patient education part. You need to educate your patient about what to do. If you experience pain, take one pill under the tongue, okay? Wait for 5 minutes. Now, two things can happen after 5 minutes. Number one, maybe the pain resolved. What you do? Just monitor. What if the pain is not resolved? First thing to do, take another one. Take another one. And the second step is, as soon as you take the second dose, call 911. Why not to call 911 first? What if you did not take the dose, which may have prevented, okay, which could happen that you started the call, you were okay, but as soon as you started talking, you were not able to take the next dose. The severity, you had no control. You went unconscious. You're not able to. So first, make yourself safe. So after 5 minutes, not resolved, the pain is not resolved, take the dose, call 911. What to do next? Wait another 5 minutes. Okay, wait another minute. 5 minutes. Once again, two things can happen. Either they get better or not. They get better, monitor, wait for the help. If the pain is not resolved, take another pill. Okay, what to do after that? All you can do is wait for emergency crew to reach. Stay on the phone, but no more dose. Maximum 3. First one you take, wait 5 minutes. After 5 minutes, if not resolved, take another one and call. Wait another 5 minutes. If still pain, take third one. That's it. And tell them, do not drive after that. Why? It's going to cause vasodilation. Vasodilation is going to drop their blood pressure. Dizzy. Is everybody clear now? Everybody knows what are the guidelines. Anything which is not clear. Anyone having any issues, any concerns? Yes, no,
Yeah,
good.
is this only for the sublingual form? Or is it
Even for the spray.
How would it work if
Even
it's like an IV?
IV is different. The patient is not going to put IV on their own. When that is a different criteria set for the staff, how they do it. Then they're already under the care of somebody. This is when the patient home, they don't have people around. They're not in the hospital. Does it make sense?
Okay, that makes sense. Yeah. Thank you.
Okay. You're welcome. Anyone else?
Is the spray like something you put in your mouth, or is it something you put on your chest? What does that work?
Or the nitrostat?
Yeah, you said there's a spray
Oh,
too.
these are little tiny pills. You put it under the tongue.
Oh, okay. Okay.
Okay. And you see on the bottom, which says nitrolingual pump spray.
Yeah.
Right? That's also, it's a spray. Same way goes under the tongue and gets absorbed right away.
Got it.
Same concept. Different formulation. But now let's go to the other side. What if the patient is using or will be using a patch, right? Patch. That's not something that is going to treat acute like right away, as you know, these nitrostat, this sublingual or the nitrolingual pump spray. So that has different educational points. So please know that as well. They are also extremely important. Now, what to do? First, if they're going to apply a patch, make sure there's not an old patch there anymore. Remove that first. Number one. Number two, where we gonna apply it? Never at the same site, rotate the site. Okay, usually like on chest or back here or here, that's where it goes. Now, the site, any requirements for the site? Yes, no hairs, okay? But do not shave. It can cause irritation. If it needs to, maybe just trim it, okay? Trim it and not fresh shave. Well, if the condition is damaged, kind of serious, well, go ahead and shave. I'm not worried about irritation at that time. I need to save the patient, right? So hairless areas and should not have any open skin there, okay, or irritation on skin. You apply the patch, just press it gently, leave it on for, I would say, 10 to 12 hours, and then take it off. Usually it's best to take it off at night. Why? The patient's workload, the heart's workload is less because patient is resting, right? When they're doing things at day, like it's more work, right? So when the workload is low, well, that's when you should give that nitrate-free period. The reason, the patient develops tolerance and then they stop responding to this drug if you continuously keep applying either the patch or kind of ointment. You have to have a nitro-free period, and usually, as I said, night is the best time. Is that clear? Okay, now either if it's a patch or it's an ointment, right? So old one, we removed it, wash it gently with soap, water, and pat dry. Don't kind of rub it, pat dry, just gently. Now at the different spot, you apply it and do not cover the area. Do not cover the area like, oh, you know what, it's hurting. Can you put a heating pad? Oh no, why? Heat, high temperature is going to increase the absorption of the drug, which can cause high risk of hypotension, adverse effects. We don't want to do that. Never cover with like a plastic or sheet, or never apply a heating pad on that. Okay, and always rotate the site. Okay, we talked about this. Now, once again, going over the same information, guys, real quick. Rapid acting for acute attacks and long acting always to prevent future ones, never for acute attacks, okay? What is the biggest concern? Contraindication. Who should not be taking it? Well, we know that this is going to cause vasodilation and drop patients' blood pressure. If somebody has hypotension, means blood pressure is low, that is a contraindication. Correct? We shouldn't be giving. Somebody has head trauma, that's a problem. Okay. Now, next thing is very, 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 and very, and very, and another very, and one more very important. Okay. The reason it carries a high risk. Okay. Your patient might end up in the emergency room. Most very highly likely. Do not give this medication with ED drugs, the erectile dysfunction drug, like your Cialis, Viagra, like your sildenafil, tadalafil, vardenafil. Do not give it. Reason. What does these nitrates, the nitroglycerin does? Vasodilate, drop the blood pressure. What does these sildenafil, vardenafil does? Dilate, increase the blood flow, but drops the blood pressure. Now, two things does the same thing. Your patient is on the floor. Okay, so this is a big thing. Do not ever, ever, ever mix them together. All clear? Okay, now about 3 things important on the slide, 3 or 4, and those are very important again. When we talk about adverse effect of drug, the patient may experience a common adverse effect, which majority of the patient may experience. On the other hand, the patient may experience the severe effect of the drug. Maybe not too many patients, but whoever experienced that, that's high risk. So with these drugs from this class, the nitrates, nitrites, right? The most common adverse effect is headache. Remember that. Most common is headache. If patients say, I'm experiencing headache, well, unless kind of it's real super crazy, they're saying you can't do that. Oh my goodness, I never kind of experienced that before. Well, that could be a high alert. But if it's just kind of, normal level of headache, well, tell them it's normal. It will go away shortly. But if it stays for longer, that could be a problem. So this is the most common adverse effect, headache. Other hand, high risk, most severe, that is postural hypotension. Hypotension is the most dangerous part we need to be worried about. So they could ask you about the most common, they might ask you about the most severe one. So please know both. Everybody understand the difference between them? Anybody who did not? Anybody wants me to repeat it? Everybody's okay?
Yeah, sorry, can you repeat that one more time?
Yeah. Okay. So any drug patient takes, they may experience the most common adverse effect or the most severe adverse effect, right? Most common means if you give it to 100 patients, maybe like 40, 50, they experienced it, right? But severe could, but it's not high risk. They may have just a headache. On the other hand, the patient may fall because of that, but out of 100, maybe it's 1 or 2 patient could experience that, but that's the high risk. And that's what is the most severe one. So if it's most common, you say, hey, this might happen because, hey, most commonly patient might experience this. So that's also important to convey. But the most severe carries a higher risk. So that's also equally important that you educate your patient, and that is the hypotension, low blood pressure. Now, third thing, tolerance. Remember the previous slide I told you it's important to give a nitrate or nitrate-free period, usually at night, right? Otherwise, the patient may not respond. That term is called tolerance. It's not addiction, it's tolerance. Now the body is not responding to similar way how it used to with the same dose. And that is the reason, in order to prevent the tolerance, we give them a nitrate-free period at night. It could vary from somewhere from 8 to 12 hours. Okay? Next. It's just an addition, which we talked earlier as well. And that is about that what is the ideal time to utilize as the nitrate-free period, and that is the night time. Okay? And going over again, if it's a patch, remove it at bedtime. It could be 10, 12 hours, whatever it can. And then in the morning, apply a new patch at a new site, not at the same site. Now, these were different dosage formulations, and these are your long lasting ones. So they are to prevent future ones, such as this isosorbide. It comes in dinitrate, mononitrate, based on their action. Then this we already talked about, guys. This is your one of the most common one, the nitroglycerin. And we talked about that what's important because it's directly absorbed, okay, from under the tongue, goes in the blood, quick action. And the reason is it does not have to go through the first pass effect, which simply means conversion of the drug administered into an active or inactive form by liver. So liver is not involved, which delays the action and also wastes a lot of drug. And that is the reason we get that sublingual. Okay. Now, next class of drug can be given, that is beta blocker. Once again, it's not for acute, to prevent future angina, myocardial infarction, simply means future heart attacks, okay? Hypertension, dysarrhythmias, okay? Now, nothing is gonna change with beta blockers. Remember, so I'm not gonna spend too much time on this. This is just another disease or condition that this beta blocker will be used for, but it's the same beta blockers, which we read or discussed in hypertension chapter, nothing different, okay? So beta blockers here as well, they're the same which ends in LOL. It's the same one who we do not give it to the non-selective who has asthma COPD, same thing, nothing is gonna change. How do they work? Well, they decrease the heart rate, they decrease the oxygen demand and increase the supply. That's how they work. Nothing different at all. Why do we give it? We talked about hypertension earlier. Here it's angina. Then there are other conditions it could be given for, such as migraine. And there's a term on the bottom says stage fright. It means the people who are scared of kind of, speaking in public, like they have to give speech, they have to present something from people, and they kind of anxious about that. Maybe one dose for that purpose could be given. That's stage fright. Okay. Now, same thing applies here. Beta blockers. We know that beta blockers do what? Slow down the heart rate, right? So when the patient takes, what's going to happen to the pulse? The pulse is going to come down, right? So before giving the next dose, you are going to do what? Check the pulse rate, right? Now, there must be a purpose why you're checking it and what you should be doing. It's not just about to check. Well, it could be normal, it could be low, it could be high. How does it impact the administration of medication, the next dose? Well, when you're checking, excuse me, the pulse rate, and remember this, if the pulse rate is below 60, pulse rate is below 60, and you as a super nurse, what you would do? Excuse me.
Notify the provider.
Hold the medication. Oh.
Hold the medication, call the doctor. Okay, all super nurses with me on that? You're gonna hold the dose, you're gonna call the doctor. And the number is below 60. Below 60, remember that, okay? That at what point? Below 60. What to do? Hold the dose, call the doctor. Got it? Okay, and tell them do not just decide that I'm not gonna take it without consulting the doctor. Now, same thing again, guys, what we talked earlier. Asthma COPD patient, high risk, right? We talked previously in hypertension as well, because it causes bronchial constriction. That is a problem. Now, let's add something here, and that's equally important. Please know that as well. Your diabetic patients. Why it is so important. Now, diabetic mellitus or patients with diabetes, what is the problem? High blood glucose, correct? Now, if they are taking some medication, either insulin, oral drugs, what are we expecting? The blood glucose to come down, correct? Once they take diabetes medication, the blood glucose should come down. And there's always risk, as we're talking about, right? Hypertension, patient has high blood pressure, you give the medication, but the blood pressure can go too low as well, causing hypotension. So patient with diabetes has high blood glucose, but there is a risk with medication that can go too low as well, right? Called hypoglycemia. Now, what happens when patient experience hypoglycemia? They show certain type of symptoms. They are shaky, sweaty, hungry, correct? That's what happens. Excuse me, guys. But if the patient took the beta blocker, majority of the symptom other than sweating, it may mask them. The patient may not have that shaky feeling, or any other symptoms. So you have to monitor their blood glucose more often if they're taking a beta blocker. Does that make sense? Be clear about that point? Okay, take it as yes. Okay. So that is important, okay? If we generally talk about that, how it impacts various organs, on the heart, what it's going to do? Gonna bring the blood pressure down, right? Which is what? Hypotension. So that is concern. Heart rate is going to go down. Bradycardia, that is a concern. As far as on the metabolic system, you have to watch both hyper and hypoglycemia. Both. It can go either way. Not extreme high risk about that, but may. So one of the important factors here is to monitor what is important: the heart rate, the pulse rate, right? So monitor for bradycardia, slow heart rate, okay? Slow rate. That is very important to monitor. Uh, I'm not worried about much about this, can cause, but very rare, okay? This is example. Once again, I'm not gonna indulge into that. We talked about these drugs that were beta blockers ending in LOL. Nothing. And same here. These are calcium channel blockers, same one, which in your hypertension chapter, right? Ends in pine. Ends in pine. Sorry, guys, give me one quick moment, okay? One moment. Okay, sorry about that, guys. I'm back. All right. So ends in pine, once again, nothing different. Same way they work, causing vasodilation, right? So I'm not gonna go into that. It's the same drug. So this is the reason you need to know how they work, what they do, because the same drug you will see for this condition, in another chapter you will see for a different condition, but none of the characteristics are changing. What are we using it for? Okay. Okay, let me add something in here. Your calcium channel blockers can also cause constipation. Okay, calcium channel blockers. So please add that to calcium channel blockers. Constipation is common. Now, what do? Well, you told them about the problem. Now it's your job to give them a solution. The solution for constipation is it's more that they're dry. Well, make them wet. Well, how? More fluids and more fiber, more bulky. That's a solution. So educate them. If they're taking calcium channel blockers, hey, increase the fluid intake, as well as more fiber, problem solved. Okay, now another important thing I want to add here is if they are taking this medication, it's not common, it's rare, but there are reported incidents, patients where they experience edema and shortness of breath. Okay, edema and shortness of breath. So that's also important. So please add that as well. And into that, let me add something else. Do not give calcium channel blockers with grapefruit juice. And that applies to majority of the drugs. Grapefruit juice, St. John's wort, they are not good idea to give with any medication. So if you see with any of the medication, say no. Okay, grapefruit juice. And the reason here in this one is the calcium channel blocker, their effect goes down, efficacy goes down, it drops. And once again, tell them do not abruptly stop them. And if not just this, any of the drug for any the condition, if it's in enteric coated form, extended release or all that, tell them do not chew or crush. Then they're dumping the whole dose all at once. These are your non-dihydropyridine. Remember, I told you only two, diltiazem and verapamil. So this is used specifically, very commonly for, or they're more effective in AFib, atrial fibrillation. Anybody knows what that is, atrial fibrillation? Anybody knows what it is? I'm sorry, what was that?
I said it's bad.
Yeah, it is bad for sure. I agree with that. But what it is?
It's like a your heart rate is going in a certain pattern or something like that, right?
Okay, so AFib or atrial fibrillation, heart is beating super fast. Even it could like 400 beats a minute. Think about that, how bad it is. Okay, that is, and it's irregular, extremely fast and irregular pattern. That's AFib. And there's another term, atrial flutter. So atrial flutter, and let me go back actually. AFib, it's no, actually, let me go to flutter. Okay, flutter, there's atrium and ventricle, right? Atrium and ventricles in the heart, they're chambers, right? So atrial flutter, it is also called supraventricular arrhythmia, supraventricular. Okay, so this is also common in this, the fast atrial rate, over, above that. So atrial rate, it's with a fixed, and the ventricular rate is variable. That's flutter. Atrial rate is kind of stable. It's fast, but stable. Ventricular is variable. That is your atrial flutter. Okay, now going next. This is again your same drugs. I'm not going over that. Same thing, guys. No matter what condition you are giving it for, you're going to monitor the same thing, like edema, weight gain. Remember, that is an indication of heart failure. Intake, output, daily weight, that is something. Monitoring pulse rate, holding the dose, calling the doctor if it's below 60, shortness of breath, because that could be a potential indicator of heart failure. We're doing the same thing. And here, changing position slowly, because these drugs are going to drop the blood pressure. And that is the reason we are monitoring. This is same thing, guys. We just talked a couple of times at least. Nitroglycerin, how to take it, right? How I told you, take it as soon as they experience angina, wait for 5 minutes. If still happening, take another one, call 911, wait. If it's still happening, take one more and wait. That's it. And if they're saying, oh, when I take it, it kind of gives like a burning sensation, nothing to worry about. It's still potent. That's all it means. Nothing to worry about. And always keep it away from direct sunlight. The drug goes bad. Okay. And once again, we talked about this topical application like patch or your ointment, right? Remove the old application first and kind of wash, gently pat dry, apply at a different spot, and do not cover it and do not apply heat on it. If somebody asks, well, can I kind of swim with it? Well, go ahead, do that, right? You can. But if it gets off, apply the new one at a different place. Okay. This one is covered already. Okay, guys, a couple of things I'm going to add here to nitroglycerin, okay? And that's equally important. So please know that and just add that to nitroglycerin. Nitroglycerin, if it's an IV form, it has to be in non-PVC tubing and the bag. Bag should not be PVC, polyvinyl chloride. Why? Because that absorbs the drug and also it can release into the drug, making the drug bad. Okay, so it has to be non-PVC bag as well as the tubing. Keep it away from direct sunlight. That's why they're in dark color containers. Third, if the IV liquid is in dark color, dark green, blue, green, whatever you see, very dark color, it's bad, toss it. Never ever use it. Understood? Any question? Any question, guys? Anything?
What was the first one again? You said there was 3?
I'm sorry, 3 what?
Because I wrote down like the bag has to be PVC. I also wrote the dark color one, but I'm missing one more.
If okay, covering it, so that it's not exposed to direct sunlight.
Okay, thank you.
Anybody else?
Yes, you said non-PVC tubing, non-PVC bag because PVC can absorb the drug and what?
And release certain part of it or the chemicals or it's made of substances and it can release those substances into the product, your nitroglycerin, which can make the drug bad.
For sure. Thank you.
Okay. Anyone else, guys? Ooh, this lady is mad. Oh my goodness. Okay. Okay. You guys want to take a quick break? Yeah. Okay. So 2:10. Let's be back right at 2:20 and we'll wrap it up. Okay. Thank you. Okay, welcome back, everyone. All right, let's turn the cameras on. Okay, let's cover the last chapter, guys. It's for heart failure. Once again, you're gonna see kind of similar type of drugs, same drugs, and we'll go a little faster on that. Wherever it's the same drug, but let's understand the concept like heart failure drugs. We're gonna give it to patients who are experiencing heart failure. So first, we need to know what is heart failure and how do we fix it, and then all adverse effects and interactions, all those kind of things, and important aspects related to your nursing care plan or process. Now, when we talk about heart failure, your patient may have systolic or diastolic heart failure. They be called like right side, left side failure. Now, heart failure simply means that heart is not able to do the work it's supposed to do. Heart's supposed to pump. And when it fails to do that, that is called heart failure, right? And it cannot supply enough blood to the body. Now, systolic and diastolic. Two ways. If your patient is experiencing systolic heart failure, what's happening? That ventricles, these, right, atrium and the top ventricles, maybe they filled fine, but they can't pump hard enough to supply the blood to the body parts. Okay, everything else could be right, but they just can't pump enough. They're not contracting enough strongly to push the blood out. That is your systolic. On the other hand, diastolic, that's your resting phase. Resting phase when ventricles are being filled with blood. Here, not enough blood is filled in the ventricles. That is your diastolic heart failure. Is that clear to everyone? Somebody asked you, systolic means they can't pump even though they have enough. Ventricles are not contracting strongly. On the other hand, diastolic, they just can't fill during that relaxed phase. Even though contract fine, but hey, they were not able to fill enough. Okay. Now, heart failure, so technically it's more like your syndrome where it's caused by different numerous cardiac disorders. So it's a pathological state in which your heart is unable to pump the blood in enough, the required amount from the ventricles to meet the body's metabolic demands or needs, right? So that's when the patient starts experiencing these symptoms. Now, common symptoms, well, that shortness of breath, right? When there's not enough supply of oxygenated blood. Fatigue, they feel tired because they can't keep up. The supply is short now. Fluid retention, pump is not pumping means it's retaining. Retaining, when it's retaining, it's backing up somewhere in the body. It's backing up somewhere in the body, and I'm going to show you a picture, next slide, how you determine if it's a left side failure or right side failure. Okay, let me give you an easy tool. Look here, left side heart failure or right side heart failure. Left side heart failure. Left side starts with L. Okay, starts with L. Lungs starts with L. If your patient has a left-sided heart failure, where you are going to notice the symptoms in lungs, the second L. Okay, left side heart failure, patient's symptoms will be evident where? In lungs. What is the function of lungs? What happens in lungs? Respiration, right? Respiration, air exchange, breathing. When there's not normal level of air exchange, breathing, what happens? There'll be shortness of breath, correct? And the fluid will back up in the lungs. So when fluid back up in the lungs, shortness of breath, difficulty breathing, and the lung sounds, crackles and all that, you can hear that because lungs has fluid in it. It won't be clear. Okay? Now, on the other hand, if the fluid backs up in the other parts of the body, such as ankle, legs, feet, somewhere, that is the right side failure. Everybody understood, all clear. Where are you going to look up for the signs and symptoms associated with left side heart failure or right side heart failure? Everybody clear? Just know one, you will know the second. LL, left side signs and symptoms associated with lungs. All right. So different conditions behind that. It could be heart failure, somebody coronary artery disease, and all kind of, there are many conditions could be behind that. Now, if you look up at different stages of the heart failure, from less severe to more severe, stage A, the patient does not have the symptom, does not have any structural abnormality which you can see, okay? But the patient is at high risk that it can happen, okay? Maybe patient has a family history, right? Or maybe patient has high cholesterol, something that risk is there, can happen, but still there's nothing. Number two, the stage B. Structurally, you can see there's some sort of abnormality like enlargement in some part or something, but patients still do not experience any symptoms yet. That is stage B. Stage 3, yet yes, structurally you see abnormality there, and now patient have some symptoms there as well. It may not be real severe, but yeah, the patient experience symptoms here. D is where clear structural damage, clear